Actually, I will speak about the evaluation of freeze-all strengths and threats. Okay. The first question, freeze-all, does it eliminate the ovarian hyperstimulation syndrome? Actually, concerning safety with elective frozen embryo transfer, significantly decrease the risk of moderate and severe ovarian hyperstimulation syndrome. And the risk of severe ovarian hyperstimulation syndrome, which is virtually eliminated in freeze-all cycles, there are certain small risks associated with retrieval of large oocyte cohort, like thromboembolic risk, large size ovaries, and rare cases of ovarian hyperstimulation syndrome. And so you should be also careful, even if you do agonist trigger, that you are aspirating large ovary with large oocyte cohort. And you should be also careful of thromboembolic risks. I have one of my colleagues have a case of left hemiplegia after freeze-all, and so you should be careful for well hydration and well thromboembolic prophylaxis. This Cochrane review by Youssef et al., our colleague, as we see here, if you give agonist trigger, it will be more safe. And so the use of GnRH agonist instead of HCG resulted in a lower incidence of ovarian hyperstimulation syndrome. And you can also use the GnRH agonist as an oocyte maturation trigger, and it is useful in other indications like our Dr. Ahmed tells us in the indications. This is a recent meta-analysis and systematic review also confirming that elective frozen embryo transfer significantly decreases the risk of moderate and severe ovarian hyperstimulation. But this is not without risks. There are some case reports, and we can call it case reports because they are not a lot. When we give GnRH agonist, we may rarely have cases of severe ovarian hyperstimulation. This report from Turkey, published in RBM online, of 3 cases. Another one by the well-known Fatemi and Juan Antonio Garcia Velasco from IVI. They reported 2 cases of severe ovarian hyperstimulation syndrome, and they attributed this maybe for the FSH receptors and the LH receptor gene mutations that can lead to ovarian hyperstimulation syndrome. And so even after you give GnRH agonist, you may be somewhat careful. Freeze-all strengthens the second question. In freeze-all, does freeze-all improve pregnancy rate? Actually, like we hear from Professor Yaoub, the cumulative live birth rate following the freeze-all strategy was similar to the fresh transfer strategy among high responders, but was lower among normal and suboptimal responders. This is the first systematic review and meta-analysis done by the Brazilian Matheus Rocchio, published in 2012. And as we see here, it was in very favor to frozen thawed embryo transfer and freeze-all policy. But actually, it was retracted, and 2 authors of this meta-analysis or 2 papers with the same author, and there were no intention to treat. If we reallocate after intention to treat analysis, we will find that there is no significant difference in the live birth rate or ongoing pregnancy rate like we see here. And so this meta-analysis was updated in June 2019 and published in Human Reproduction Update with intention to treat analysis. And as we see here, there is no significant difference as regards the live birth rate and as regards the cumulative live birth rate after 12 months. And so the authors stated that although the use of elective frozen embryo transfer has steadily increased in recent years, a significant increased live birth rate with elective frozen embryo transfer was noted in hyper responders and in patients undergoing BGTA. And again, concerning safety, elective frozen embryo transfer significantly decreases the risk of moderate and severe ovarian hyperestimulation syndrome. This well-known paper of SART analysis, Society of Assisted Reproductive Technology registry, published in Fertility Sterility by Sohail Maashar, it stated that in high responders with 15 oocytes or more, as we see here, if you have more than 15 oocytes, this in red is the freeze-all policy. You have a higher live birth rate than fresh transfer, and also higher clinical pregnancy rate than fresh transfer. But if you have less than 15 oocytes, and if you have less than 5 oocytes, and so the fresh definitely is better. This is the Cochrane review in 2017, and it stated that there is no significant difference also between freeze-all and the fresh in live birth rate as a general, and ovarian hyperestimulation syndrome is better outcome in freeze-all, of course, and this is very interesting about the birth weight. If you speak about singleton, you will have larger baby in frozen cycles, but astonishingly, this was not the case if you have multiple pregnancy. There is no difference between freeze-all policy and fresh transfer. These cumulative live birth rates following a freeze-all strategy, it was a population-based study. Actually, if less than 15 oocytes, fresh is better than freeze-all. As we see here, if you have more than 15 oocytes, fresh and frozen or freeze-all is comparable prognosis, and it will give both of them the same cumulative live birth rate. But there is a difference between fresh and frozen if you have less than 10 oocytes, or if you have from 10 to 15 oocytes. And so definitely if you have less than 10 oocytes, or if you have 10 to 15 oocytes, fresh embryo transfer is the best. Another question, does it improve obstetric outcome? It is very important about the safety and obstetric outcome. This is a very important publication by Abha Mashauri, and it said that if we can cumulative meta-analysis provide a definitive answer, and the result of this cumulative meta-analysis confirm that the decreased risk of a small for gestational age, low birth weight, and preterm delivery, and the increased risk of large of gestational age and high birth weight associated with pregnancies received from frozen embryos has been consistent in terms of direction and magnitude of effect over several years, or those studies. Another important issue about the risk of ectopic pregnancy is in this very interesting study. And as we see here, if you transfer fresh cleavage embryos, you'll have more ectopic than if you transfer fresh blastocysts. And if you transfer fresh blastocysts, you'll have more ectopic than transferring frozen blastocysts. And so the best or the least ectopic incidence is transfer of frozen blastocysts. And so this is in favor of the freeze-all, especially in hyperresponders. Another one about ectopic pregnancy by Laura Landra from Johns Hopkins, USA. For a large number of cycles, 1,003 cycles, the odds of clinical or ectopic pregnancy were 65% lower in women who had a frozen compared with fresh transfer in autologous cycles. And this may be the difference in the tubal uterine environment contributes to the abnormal implantation after IVF. This is another article in RBM Online in press. They found that when they search in literature, a lot of meta-analysis confirming reduced ectopic pregnancy with frozen thawed embryo transfer versus fresh embryo transfer. But in their cases, in this center, they observed a sharp decline in the ectopic pregnancy from 1.8 to 0.6%. And they said that the reasons, number one, that they implemented in-house hysteroscopy and so discovered some endometrial problem. The second is the endometrium restrictive embryo transfer policy, more restrictive policy in polyps, cesarean section scars, and hydrosalpinx. And the third, that the increase in freeze all cycles make the ectopic less. in the last years. And so freeze all in cases of patients with previous history of ectopic may be recommended. Freeze all, does it solve some pre-existing problems in IVF in our practice? Actually, with freeze all, we can have more oocytes. We can do embryo accumulation in poor responders. We can make easier scheduling. We can have random start, and we can serve oncofertility patients. Like we see in the last presentation, this is very famous by Sesson Kara in 2011, that if you reach from 15 to 20 oocytes, this is the best, and the plateau for the best you should seek in to improve your live birth rate. And also, not only in high responders, you need more oocytes. Actually, again, in poor responders, especially if the patient is old age, you can seek for accumulating oocytes, because to have one eubloid blastocyst in the age of 40, you should have around 9 metaphase 2 oocytes. And to have 16 metaphase 2 oocytes, you will have only one eubloid blastocyst in the age of 43 in this study. And so you need many oocytes, and you can accumulate, and this can help by freeze-all policy. Solving the problems in practice, actually, like Professor Hisham told us, that at 3 follicles of 17 millimeter diameter, triggering of oocyte can be delayed. If you freeze all, you have the capacity to delay this cutoff limit. And also in high progesterone level, it becomes less important if you freeze all. You can make cycle programming, random start of stimulation in oncology patients and in poor responder patients like their stimulation, and avoidance of retrievals during weekend could be accomplished easier. It is not advantage without threats. There are some threats, and some important issues should be solved before we go on freeze all policy, like cost increment, like obstetric outcome with some threats, and like change in the lab practice guidelines, and improving your freeze all policy needs to improve your lab practice, because you cannot do with the same way like before, because you need better results. For the cost effectiveness, actually, for the cost effectiveness, the freeze-all policy is cost-effective strategy when compared to fresh embryo transfer as regard ongoing pregnancy. And it is very important that most of the researchers nowadays, the delay between freezing and embryo transfer could be kept to the minimum. You should not stop or wait for many months. And another important research by Ernesto Posch in Frontiers of Endocrinology 2020, there is no difference in cost in freeze-all policy when compared to fresh embryo transfer as regard live birth rate. This is also a very interesting study by Ben Moll, a cost effectiveness analysis of freeze only of fresh embryo transfer in IVF of non-PCOS women. As we see here, you can have a high effectiveness, and the effectiveness here is measured by live birth rate, but with high cost. And so you can increase your effectiveness, but with it, there will be increase the cost, and it is not without cost. And he divided the cost to direct cost, direct non-medical cost, and indirect cost. And even it is that she can, the woman can will leave her job in the second cycle for a few days. And it was found, like we see here, like around 10% more increase in the cost between the freeze only and the fresh embryo transfer. And so the cost-effective analysis of data from randomized controlled trial shows that there is a low probability of the freeze-only strategy being more cost-effective than the fresh strategy from patients' perspective of non-PCOS patients undergoing IVF-XZ in middle-income country. So it is very important, I think, in our country is patient counseling, like I discussed with Professor Yaoub. Counsel your patient, please. And from the start, counsel your patient, and you should confirm if you have more than 18 follicles, 11 millimeter or more during stimulation, you should re-counsel your patient that freeze-all is the best. Second, you can counsel your patient that the total cost of the drugs is less than the other patients. And if you take, this patient will take just 2 amps per day or less, her neighbor will take 4 amps. And so the money will go for freezing, but this is better for the safety, and safety worses, like Professor Yaoub said. And we will counsel our patient again that there is 10 to 15% at least cost increment, but this is for her safety, and it is a one and done approach in hyper responders. This is better to retrieve once and have many transfers after that. What is the risk of perinatal outcome? The first one is macrosomia, and we know that there is a growing concern that children born after frozen embryo transfers have increased the risk of large for gestational age and or macrosomia. Brentson and Bimborg evaluated the association between frozen embryo transfer and large for gestational age in a meta-analysis consisting of 10 studies on large gestational age and 6 on macrosomia. Definitely large gestational age was increased 1.5 folds and 1.3 folds compared to fresh cycles and natural cycle, respectively. And similarly, 1.7 fold and 1.4 fold increased the risk of macrosomia compared to fresh embryo transfer and the natural cycle, respectively. Why? Why large for gestational age? It remains uncertain, but many explanations like prenatal characteristics and the freezing thawing procedure itself, which might be inducing epigenetic changes during vitrification thawing. Uterine environment in frozen cycles is generally more natural synchronization between the embryos and the endometrium. This is again by Ernesto Bosch in 2020. It shows that there is a hypertensive disorder risk confirmed, especially with hormonal replacement treatments, and this is besides the other risk we mentioned. But as a general, some neonatal outcomes such as antepartum hemorrhage, administration of the neonatal intensive care unit, congenital anomalies, and perinatal mortalities, there are no differences reported between frozen and the fresh embryo transfer. This report is very important. In 2019, in December, about frozen embryo transfer tied to cancer risk in kids. The data for more than 1 million children born in Denmark between 1996 and 2012, they found that the rate of childhood cancer was 44.4 per 100,000 for children born using frozen embryo transfer, compared with only 17.5 per 100,000 children born in fertile women. There wasn't an increase in risk in children of couples who used other types of ART technologies rather than frozen embryo transfer. But actually, after rising of this very important paper, there is an expert reaction to frozen embryo transfer. One of that were by our dear guest, Professor Yaoub, that the risk of childhood cancer would be 1 in 2,000 at worst, which, although serious, is considered rare. Another comment by Al-Sadir and Rankin, while a doubling of relative risk sounds scary, the childhood cancers are very rare. And so the absolute risk is still low. And actually in Denmark, the childhood cancer is higher than other areas. And so there is still a lot of question for that, and the risk is very minimal. The last important thread is the level or the cryopreservation technique itself that should be optimized before you start the freeze-all policy. So we cannot understand to start freeze-all policy without optimization of the cryopreservation technique. And so it is very important to have these alpha key performance indicators. This is from the alpha consensus meeting of cryopreservation key performance indicators. The key performance indicator, you have a benchmark indicator and the competency level. The competency level is the minimal level of performance of vitrification that you can do in the lab to perform a good quality vitrification process. And the benchmark is the best achievable results. And so every good lab should be between benchmark and the competency level. This is a desirable range that you can be in between. And so for blastocyst, key performance indicators, as stated by this alpha group of embryologists in 2012, for vitrification. This is for the slow freezing, and nowadays I don't think that anybody is doing still slow freezing, and this is for vitrification. For vitrification, if you have 80% of your blastocysts survived after thawing, you are good. But if you have 95% of your blastocysts survived after thawing, you are excellent. This is the benchmark. If you can transfer 80% of your thawed blastocysts, they are okay, you are good. But if you can transfer 95% of your thawed blastocysts, you are excellent. Again, for the implantation rate, if you have the same implantation rate in thawing and fresh embryos, it is an excellent performance. And if you have till 10% lower, you are still okay. And so by these KPIs, every lab could adapt and evaluate the performance. Another important point is not only the camera, it is the man behind the camera. And so the embryologists are very important, and the number of embryologists and the training of the embryologists is very important. Actually, those are different guidelines, one by the SRM in 2008, one by the ISHRI in the revised guidelines for good practice and IVF lab in 2015. And I think this is the most conservative and most important one by the Alpha Consensus meeting in 2015, also in RBM Online, because in this you should have one embryologist for every 120 cycles, either fresh or frozen. So if you can imagine that you have 200 fresh and frozen cycles a year, you need 10 embryologists. This is a very important paper by the team of Obaldi and Roma and Laura Renzi from Italy, and they are very well known by BGTA cycles and a lot of freezing. And they recommended from their practice to improve your freezing system that blastocyst artificial shrinkage involving a lower risk of degeneration after warming seems to be better tolerated from a collapsed blastocyst. The trophoectoderm biopsy did not show any association with degeneration. What is more important, it is the pre-vitrification features or the post-warming feature. Actually, the pre-vitrification features, the morphological quality and the day of full development is more important than the post-warming features. That's it, degeneration and re-expansion scores and morphological quality. And the fourth most important point, that poor morphology quality pre-vitrification resulted in significantly higher degeneration rate. Other lab techniques that could be improved, some embryologists prefer DEMSO-free media, and some labs prefer vapor tanks. These vapor tanks can reduce risk of cross-contamination, less liquid nitrogen usage, saving money, and easy use for handling, and more cost effectiveness according as regards space and capacity. Also, you can vitrify in compact morula. It may be less easy and better as regards degeneration. And so nowadays, the EFRI is running a multi-center study comparing compact morula and the blast vitrification and thawing, and we hope to see the results sooner. Lastly, this is how to optimize your endometrial preparation protocol, and I think Professor Yaoub has a lot of discussion about it, but I will explore our protocol in our center. We started the estrogen 6 milligram to 8 milligram daily from day 1 to day 2. At day 6, we have ultrasound evaluation and measuring E2. If the estradiol level is less than 300, we increase the dose. After 10 or 11 days of estrogen and with endometrial thickness, better to be 9 or more and at least 7 millimeter. And we insist on the pattern, like Professor Yaoub mentioned, we start progesterone. For day 5 embryo transfer, we started progesterone with 1 suppository 400 milligram at night and 1 ampoule in the morning. At day 5 morning, ampoule of progesterone is given, but 2 hours before we can measure progesterone. If the progesterone is less than 10 nanogram, we increase the dose. On day 6, we usually transfer after between 120 and 144 hours. Management after transfer for day 3 and day 5 transfer, the patient will continue the same dose of estrogen and progesterone after pregnancy. With positive pregnancy test, we will continue. And with positive pulsation, we can stop the ampoules because it is very hard and painful for the patient, except if you give subcutaneous. And at 10 weeks, we stop estrogen, and at 10 weeks, we'll stop progesterone suppository, and the placenta take over. So a few take-home messages concerning safety. Elective frozen embryo transfer significantly decreases the risk of moderate and severe hyperstimulation syndrome. The cumulative live birth rate following the freeze-all strategy was similar to the fresh transfer strategy among high responders, but was lower among normal and suboptimal responders. Freeze-all policy is a cost-effective strategy when compared to fresh embryo transfer as regards ongoing pregnancy. No differences in cost as regards live birth rate. Thank you.